not unusual that the guideline, that stuff gets missed. On the flip side, doctors are extremely picky. If you kept alerting them for every heart failure patient, give beta blockers when, for example, the patient is allergic to beta blockers, they would very rapidly turn off the system. So again, it's very important to be able to do this extremely accurately. So now that let's talk about the two corresponding application areas. So one area is, how can we, this is the challenge today, how we have guidelines that are known, and how do we make sure that the patient is treated according to the guidelines? How do we take the medical knowledge that is known and bring it to bear on this mixed patient record, which has got information not in a nice structured database, but in all this free text and images and labs and billing data spread over time, to the future where we are starting to go from how should a patient be treated according to the guidelines, which are basically 50,000-foot guidelines that apply to everybody, to how should each patient be treated optimally. And of course, the very exciting frontier over here is genomics and proteomics, but that's probably 10 to 15 years away from translating to the bedside for a number of reasons. But regardless, we believe that with the right knowledge, even without going down to the level of the genome, you can start to personalize medicine. I'm going to take a short segue and talk about what I see as an analogy over here. So, if you look back at industrial, like the car, the way the industry started was everything was a one-off, right? In the earlier part of the car industry in the 1900s, there were as many car designs, as there were cars, literally. Then you went to mass production, Henry Ford, you can have any color as long as it's black. And now you're starting to see a focus on lean productization and mass customization. And the difference here is the knowledge. In the original situation, it was an artist at work, the knowledge was in the worker. Then it went to a situation where the knowledge was sort of in the boss, who said, this is the way it's done, and there's no change. And now really you've gone to a situation where the knowledge must permeate all levels of the organization, including the user who needs to know what all the options are. The analogy in healthcare delivery is actually pretty similar. For a long time, doctors as guards. All the knowledge is in the doctor. You go there, and basically what the doctor tells you is what happens. In the late 90s and starting now, we had disease management come in as a paradigm, which has failed not because it isn't really disease management, it really became cost management. I mean, we've all gone through the experience of trying to get a test and getting it approved, and it had nothing to do with whether it was the right thing for you or not. It was cost management. And now you're moving to patient-centric healthcare, and the key drivers are still the same. The knowledge has gone from being in the hands of the doctor to being in the hands of the HMO and the agency which tried to legislate medicine, which fortunately has led to a backlash. And now the idea is, how do we get knowledge in the hands of the consumer at all levels of the organization, including the users, which is us? And from the IT point of view, how do we get knowledge into the system, into the decision support system, so that we can help the doctor at the point of care? Okay, better speed up. All right, so applying knowledge to the patient record. What is the fundamental problem? So the question I asked, which is, does this, all patients with heart failure should get beta blockers? So the question is very simple. Is this a heart failure patient? Should the patient get beta blockers, meaning are they in the 5% that are allergic or have contraindications or not? And have they got beta blockers? If you've got answers to these three questions, figuring out the right thing to do is trivial, right? If it's yes, yes, no, raise an alert, right? If the patient's not allergic and should get it and doesn't have it, raise an alert. That's not hard to do. So if we had those data fields in our database, this would be trivial for us to build a system. The problem is the information's here. If you hand it to a physician, he or she can put their knowledge to bear to figure out how to do it. We in Siemens have developed a system called Remind, which essentially takes this mixed information and does exactly what the physician does, uses external knowledge, and I'm not going to go into details about how this works, but just show you some results. External knowledge, which in this case is simply an XML configuration file, that takes all the data and brings the knowledge to bear to extract high-quality clinical data with extremely high probability. So pulling out information from different parts, combining it based on medical knowledge. So maybe you don't have to rely, a physician doesn't have to rely on a data field. For example, let's take diabetes, which is one of the most important things, complications to know about a patient. Physician doesn't have to rely on an entry in a database. A physician can look and see, is the blood sugar high? Is the patient on insulin? And figure out from these two factors if the patient's a diabetic. So essentially, they're applying the medical knowledge. And there's no reason a system can't do the same as well. How effective is this? And I'm going to just fly through a couple of examples. We used it at a site to identify patients who need a critical therapy and ICD, which is an implantable cardiac defibrillator. There's a guideline with certain criteria which are not stored in a structured database. They need to be extracted. And the patients who are eligible have a 70% chance of dying from sudden cardiac death in the next 9 months. With the ICD, they're expected to survive 5 years. So you'd say these are extremely sick patients, and you would think there's no way such patients would be missed. But we've done studies, and here's a study at a small physician practice of 60,000 patients. We found 383 patients, and we then did a study, and we found that we had over 90% specificity in our recommendations, and an estimated 100% sensitivity. There's no way you can figure out your actual sensitivity because no one's going to go through 60,000 patients and tell you who you missed. But at least based on sampling, we seem to do right. So the point is there are people being missed, and it's very simple to actually have a system go through the data. If you have the ability to analyze data in all this different form, you do some machine learning, but you build it upon the knowledge base of what is already known as opposed to starting from scratch. And you can have profound impact on patients' lives and quality of lives. About half these patients all these patients got an exam, and about half of them were then scheduled for getting a defibrillator. That's quite a nice feeling to realize that you've profoundly impacted the life of about 150 people by running a computer program on their data. Since I'm running behind, I'm just going to fly through other stuff where we looked at extracting information and determining the quality of care and demonstrated that our system can do better. Just give you a final example. To find patients who are eligible for clinical trials. And as you know, this is a huge bottleneck. Trying to find patients who are eligible for trials is one of the biggest reasons trials are expensive and take so long. And just to show you, as a result, again, of analyzing the mixed data, as opposed to simply looking at the structured information, looking at all the information, images, free text, etc., it took him 7 patients, and this is one of the most respected institutions in the United States. I'm allowed to reveal the results, but not the name, for obvious reasons. 7 patients, they took 9 months to enroll using our system. They got the remaining patients in a week. And we are in the process of deploying this across the state of South Carolina over several million patients. So this is a very interesting time. So that's the challenge of moving from trying to do evidence-based medicine. So now if you look at personalized medicine, it actually becomes very straightforward. The knowledge module you plug in which you have the guidelines, instead simply plug in, if you can get it, a personalized